Good afternoon, everyone. This is the WPS proposed local coverage determination, or LCD, open meeting to discuss specifically botulinum toxin injections. Today is Thursday, April 30th, 2026, and the time is now 2:01 p.m. Eastern Time and 1:01 p.m. Central Time. I'm Dr. Joelle Blahakis. I'm one of the contractor medical directors with WPS, and I'll be facilitating, moderating this meeting. So the purpose of today's meeting is to take comments from stakeholders on the proposed botulinum toxin injection LCD. Before we begin, I'd love for my WPS colleagues to introduce themselves, starting with the CMDs who are on the call, and we'll go in alphabetical order by last name.
Good afternoon. My name is Denise Nachatsky. I'm one of the CMDs at WPS. My specialty training is cardiology, and I reside in Lower Delaware. Thank you.
And Dr. Campos, are you on the line?
I am. Good afternoon. I am Dr. Campos. I'm a CMD at WPS. Thank you.
Good afternoon. I'm Dr. Juan Shenin. I'm one of the CMDs for WPS. Welcome to our open meeting.
Thank you all. Will our esteemed policy coordinators please introduce themselves?
We'll start with you, Andrea.
Good afternoon. My name is Andrea King, and I'm one of the WPS policy coordinators.
Hi, I'm Michelle McCary, and I am the supervisor of the policy department.
I am Tara Schrader, and I am a policy coordinator.
And do we have any other WPS personnel on this call?
Good afternoon. I'm Radhika Trivedi. I am the policy researcher for the team.
And I am Richard Staley. I am the policy administrative assistant and the troubleshooter for the team's program. So I'm running the PowerPoints and making sure teams run smoothly in spite of Citrix.
And we all appreciate that very, very much, Rich. Thank you. All right, so I'll take the next several minutes just to go over some procedural matters, some ground rules, and then we can start taking comments on the proposed LCD. So importantly, this meeting is being conducted in accordance with CMS Internet Only Manual Publication 100-08, Chapter 13, Section 13.2.4.4. Our purpose is to take public comment on the proposed LCD, and that is the only business for today's meeting. Today's meeting is open to the public and is being recorded and will be transcribed. Both the recording and the transcription will be posted and available on our website in a few weeks. You'll notice all callers are currently muted. I will introduce the proposed LCD up for comment and then invite those comments. There are two types of comments that we are taking today. One is a formal presentation, and those have been pre-submitted and registered in advance. And any public, in addition, any public comments that we might have. Those wishing to comment may click on the raised hand icon on Teams, or if you're calling in by phone, by pressing *5. When you are called upon to speak, please make sure that your microphone is on, of course, at your end, and that your speakers are silenced to prevent any echo. Dial-in users use *6 to unmute Teams. Now, prior to commenting, please introduce yourself, state your affiliation, and indicate whether you have a conflict of interest and what that conflict of interest might be. When making your comments, please be as specific as possible so that you can better help us improve the proposed LCD. And if a previous speaker has already made your point, there's no need to repeat it. If you do wish to go on record, you can simply say that you agree with the previous speaker. Now, each speaker will be allotted 10 minutes to give equal time to all who wish to participate and comment. Mr. Staley will provide a 2-minute warning, and I will ask the speaker to stop at the 10-minute point. If a speaker has a slide presentation, one of our WPS team members will advance the slides to avoid any possible technical difficulties. Our purpose today is to listen to your comments, so we typically do not respond to questions or make comments during this meeting, but we may ask questions of any speaker. Please be aware that only comments or questions submitted to Medicare Policy Comments at WPSIC.com will receive a written response. Please include the topic of the LCD on the email subject line. So for this, botulinum toxin injections. If you have supporting scientific literature, please attach that either in PDF or Word form to your email. Unfortunately, WPS cannot follow or open email links. All responses are for educational purposes only and do not establish Medicare or WPS policy. Comments will not be addressed individually, but will be compiled and addressed in a response to comments document posted with the final LCD. Okay, now we're ready to present the LCD. Do we need to advance the slide? There we go. All right, so the open comment period for this LCD is from April 2nd, 2026 until May 16th, 2026. The proposed LCD DL 39909 is entitled, of course, botulinum toxin injections. It's important to note that this is a collaborative multi-MAC LCD written in conjunction with this, the list of participating MACs here, including WPS, of course, CGS administrators, Palmetto GBA, First Coast Service Options, Meridian, and WellPoint Federal, formerly known as NGS. This LCD is the responsibility of Policy Coordinator Andrea King, who introduced herself earlier, and myself, Dr. Joelle Blahakis. All right, let's go on to summary. So DL 39909 is the updated botulinum toxin injections local coverage determination, or LCD, which provides clarification regarding adherence to FDA serotypes, as well as dosing guidance and requirements. So this LCD is quite lengthy and covers multiple indications listed here. So I'm simply going to summarize the most significant changes of this proposed LCD from the current effective LCD, which was posted on March 26, 2026. All right, next slide, thank you. So under the general indications and limitations of coverage, we have deleted number 7 entirely, which refers to when botulinum toxin is used for an approved diagnosis, but the botulinum is also being used with cosmetic intent. The entire claim for the botulinum is not considered reasonable and necessary. We've also changed the language of number 15 to image guidance is not considered reasonable and necessary for injection of Botox, except for certain conditions outlined in the policy and article. We added number 17, which states, when the FDA makes changes in a serotype's approved indication or dosage, those changes will take precedence and be allowed Medicare coverage. We added number 18, which states off-label use of botulinum serotypes for various indications and our dosing are intended to be evaluated and covered under the policy only in unique circumstances with robust published clinical evidence, such as medical society guidelines. All right, next slide. So specifically under individual conditions, for blepharospasm, we added number 2, the initial treatment with Incabotulinum toxin A for blepharospasm associated with dystonia is 50 units or 25 units per eye administered to the affected facial or ocular muscles under initial dosing guidelines. We deleted up to 5 units per site in number 5 under subsequent botulinum toxin injections. And we deleted number 1 under subsequent dosing guidelines and replaced it with the following. For Incabotulinum toxin A and blepharospasm, subsequent doses could be increased to 100 units per treatment session, 50 units per eye administered to the affected facial or ocular muscles. Under blepharospasm associated with orofacial dystonia, we have another slide, Rich. We updated number 1 to change submentalis to mentalis in the following sentence. I won't read that. That's simply just more correct. Let's go on to cervical dystonia. Under subsequent dosing guidelines, we updated number 4 to change units per treatment session from 120 to 400. And then under laryngeal dystonia, we corrected under the diagnosis section a typographical error. I won't go into detail. You can read that here. And we also further clarified the typical presentation as adductor type and clarified the evidence-based guideline for that type. Next slide. Number for upper and lower spasticity, we corrected under initial dosing guidelines the dose units from 8 to 15 to 8 to 16 in the following sentence. The initial, the total initial dose of abobotulinum toxin for upper limb spasticity must not exceed a dose of 8 to 16 units per kilogram per upper limb, up to a maximum of 1,500 units per upper limb. And then under the bibliography, we corrected and added reference number 333 and 334. Next slide. Okay, so throughout the coverage indications, limitations, and medical necessity section, we changed diagnostic procedure to botulinum toxin procedure. And then under the analysis of evidence section, again, citation 333 was added. Under the chronic migraine section, we further clarified at least 5 attacks fulfilling criteria B and D, and then we changed that to at least 5 attacks fulfilling criteria 2 through 4. And again, we made a similar correction. At least 2 attacks fulfilling criteria B and C was changed to at least 2 attacks fulfilling criteria 2 and 3. Next slide. Under upper and lower spasticity, required was a change to allowed. And number 4 under initial botulinum toxin injections, as well as subsequent botulinum toxin injections. Ooh, okay, thank you all for sticking with us this long. I also want to thank you for your general attention and interest in this policy. You help us do good work, and we do that together. So our first formal presentation was given to us by Amandeep Man, and he is from Ipsen Biopharmaceuticals. And with that, I'm going to put myself on mute.
Thank you for the introduction. Amandeep Man, I am representing Ipsen Biopharmaceuticals. That is the manufacturer and provider of Dysport, also known as abobotulinum neurotoxin. Next slide, please. Disclosures for me are that I'm a full-time employee of Ipsen and hold shares of Ipsen stock. Next slide. This presentation is in response to MAC request for feedback on updated MAC draft LCD policy consistent with the FDA-approved uses of BoNT/A for the Medicare population. Ipsen does not recommend the use of its products or any other products in any manner other than as described in the FDA-approved prescribing information. Ipsen Biopharmaceutical wants to recognize and thank the members for efforts in updating this very comprehensive BoNT LCD policy. I'll walk through some key sections in the draft LCD policy that we feel need clarification and updates to ensure that the policy is aligned as per the FDA-approved labeling for Dysport or abobotulinum neurotoxin, in addition to the published evidence around Abobont-A. IPSIM will follow up with a detailed response, including all relevant supporting references to consider for the final LCD policy. Next slide, please. Abobont-A for therapeutics is approved by the FDA for the treatment of cervical dystonia in adults and the treatment of spasticity in patients 2 years of age and older. Please refer to the approved Dysport abobotulinum prescribing information for complete details on the box warning of distance spread of toxin effect and other details. Next slide, please. Abo has been available in Europe since 1990 and was first approved in the US in 2009. It has been marketed globally for over 40 years with over 5 million treatment years of patient experience and over 1,300 peer-reviewed publications globally across multiple indications, including but not limited to cervical dystonia and spasticity. Next slide, please. Our first request is to correct the language for Dysport abobotulinum neurotoxin for initial dosing guidance for adult lower limb spasticity to align with the FDA-approved label. The approved FDA Abobont dosing in the label, it includes up to 1,500 units. And this is as per our registrational trial that only showed 1,500 units versus placebo had a significant effect in reducing mass in adult lower limb spasticity patients. Next slide, please. Our second request is to correct the language for dosing limits in the subsequent dosing guidelines to adult upper limb spasticity to include 1,000 units, lower limb spasticity to have 1,500 units, and total body dose should not exceed 1,500 units. And this dosing is as per the FDA-approved label, as well as our registrational trials for both adult upper limb and lower limb spasticity. Next slide, please. The third request is to clarify that the dosing limits described in the subsequent dosing guidelines are applied to pediatric beneficiary. I do appreciate that the max dosing was corrected to 16 units per kg, but just wanted to reiterate here that the weight-based dosing limits are aligned as per the FDA-approved label are 16 units per kilogram for pediatric upper limb spasticity, and the max total body dose is 30 units per kg or 1,000 units in the pediatric population. Next slide, please. The last part is to clarify the use of EMG and ultrasound relative to indications of cervical dystonia, as well as upper limb and lower limb spasticity, specifically in the Abobont-A prescribing information. The use of guidance is recommended and as per the approved prescribing information. Additionally, I wanted to share there is published literature that indicates the use of guidance techniques may assist in mitigating adverse events by helping to visualize target injection sites. This data is also supported by recent evidence that we have generated with Abobont-A in a phase 4 study in adult lower limb spasticity that showed patients actually had improved patient goal attainment in those that were injected with Abo using ultrasound when compared to those treated with ultrasound, those treated without ultrasound guidance. So just clarifying the addition of use of guidance in both of these sections of the LCD. Next slide, please. I want to thank you for the opportunity to be on the agenda and speak. As mentioned, you will receive a written detailed response from IPSIN with the feedback on the corrections requested for Abobont-A and the PI for your review for the policy update. Thank you.
Thank you so very much. And now I believe that we have, Rich, correct me if I'm wrong, I believe that Eric Busby is our next speaker.
Yes, Dr. Busby, I will get up that one.
Can you guys hear me?
Loud and clear.
Okay. All right. Hello, everyone. My name is Eric Busby, and I am Director Medical Payer Strategy, and I represent AbbVie U.S. Medical Affairs. So on behalf of AbbVie, the manufacturer of onabotulinum toxin A, also known as Botox, and the patients that we serve, we would like to thank you for the diligent work that has been done to develop this well thought out botulinum toxin injection policy and allowing us to comment on the reconsidered LCD. Additionally, all proposed language will be provided with the written comments. Next slide, please. I am a full-time employee and shareholder of AbbVie. So today I'll focus specifically on areas within the reconsidered policy that impact patient access and clinical decision-making for Botox across 3 key indications: chronic migraine, cervical dystonia, and overactive bladder. So our goal is to ensure the policy aligns with clinical evidence, guideline recommendation, and real-world practice while preserving appropriate provider flexibility and patient access. Next slide, please. So the first key area I want to talk about is chronic migraine. So here our overall message is that we want to remove unnecessary step edits. So the draft policy requires 2 2-month trials across multiple oral classes prior to Botox. We respectfully request removal of this requirement as it is not supported by current clinical guidelines. So per AHS consensus and global recommendations, CGRPs and Botox are both appropriate preventive options and not strictly step dependent. And why does this matter? This requirement introduces delays in care, particularly for those patients who can't tolerate oral therapies, patients that have contraindications or have already failed prior therapies. It also does not adequately account for, the policy doesn't adequately account for combination therapy, which is increasingly used in clinical practice when monotherapy is insufficient. Ultimately, aligning with guidelines supports more timely and individualized patient care. Next slide, please. So continuing with chronic migraine, so here we would like to simplify and standardize outcomes. So the policy currently requires tracking both reduction in headache days and also reduction in headache episodes. So we recommend consolidating to a single clinically meaningful endpoint, which would be a greater than or equal to 50% reduction in monthly headache days. And so this aligns with the clinical trial endpoints, the real world clinical practice. So tracking multiple redundant measures creates administrative burden without added clinical value. And also on the disability measures. So we support inclusion of functional outcomes, but recommend flexibility in tool selection rather than mandating specific thresholds. And so this approach maintains rigor while improving provider usability. Next slide, please. So the second key area I want to focus on is around cervical dystonia. So here overall, we want to remove moderate to severe restriction and also allow clinical judgment. So the draft policy requires classification of cervical dystonia as being moderate to severe. We respectfully request removal of this language. And why we're asking this is that neither the FDA labeling nor AAN guidelines require severity stratification. Cervical dystonia is a heterogeneous condition, and patients with mild posturing may experience significant pain and functional impairment. Also, I want to address the equity concerns. So severity thresholds may disproportionately limit access, especially for those patients with limited specialist access and also underserved populations. And so regarding the objective measures here, again, we support objective assessment, but tools like the twisters, they are not designated for routine clinical use. So they do not reliably distinguish severity categories. And so our recommendation here is to allow diagnosis via clinical evaluation and differential diagnosis with flexibility and assessment tools. Next slide, please. So the third key area I want to mention is around overactive bladder. So here we want to avoid restrictive dosing caps. So the draft policy specifies 100 units for initial dosing and 100 units for subsequent dosing. So we request that the policy allows dosing up to 200 units, which is consistent with clinical evidence and guidelines. And so there's evidence that support this 200 units that we will be providing to you, and that would include the AUA guidelines. They support dose escalation to 200 units and those patients with inadequate response to 100 units. Also, there's an NIH-funded trial called the Rosetta and other studies that demonstrate safety and efficacy at higher doses. And why does this matter? So if we're restricting these patients to 100 units, this may result in suboptimal symptom control, and it also limits physician ability to individualize treatment. And as you are aware, the max dose of Botox is 400 units over a 12-week period. So this is not about extending label guidance. It's about ensuring that the policy does not unintentionally function as a hard cap, limiting clinically appropriate care. Next slide, please. Before I go into the summary, I do want to make mention, we noticed that in the WPS LCD, it lists ultrasound as covered code in the article, but it does not align to the language in the policy as the other 4 LCDs have language in the LCD. So we're just going to request revision of that statement in the LCD to include the word ultrasonography, which would align with the other 4 LCDs. So here in summary, we respectfully request 3 key considerations. 1, removing step therapy requirements and chronic migraine that are not guideline aligned. Number 2, simplify outcome measures to reduce burden while maintaining clinical validity. And the third thing is to preserve provider flexibility in both cervical dystonia severity assessment and overactive bladder dosing. And so these refinements will help ensure that the policy reflects current evidence and guidelines, that it supports individualized patient care, and also avoids unintended barriers to access. So thank you guys again for your time and consideration.
Thank you so much to our last previous 2 speakers. And I was remiss, a couple of things. One is just to remind everyone that that we are recording this session so that we can transcribe it. No other recording is allowed at this time. And then I also was remiss, I did not ask my colleagues, my CMD colleagues, if they had questions for our first presenter. So do you have any questions for our first or second presenters?
This is Dr. Shannon. I have no questions. Thank you.
No questions from Dr. Campos.
No, either from Dr. Nichatsky. Thank you.
Wonderful. I also want to thank our last 2 speakers because they did a brilliant job, such a good job that Rich didn't even have to give them the 2-minute warning, which is impressive. Yeah, thank you both for your thoughtful comments. Our next speaker is Dr. Erin Shriver, and I know you've been patiently waiting, and hopefully this worked out for your schedule.
No, thank you. I very much appreciate the opportunity to speak with you all today. I'm speaking on behalf of the American Academy of Ophthalmology, of which I'm a board member. I'm also a member of the American Society of Ophthalmic, Plastic, and Reconstructive Surgeons. And these recommendations and this slides have been developed by both of those organizations as well as the North American Neuro-Ophthalmology Society. So I'm speaking on behalf of all 3. And next slide, please. I have no relevant financial disclosures. I will say that I am an oculoplastic surgeon and I inject patients with blepharospasm, Mage syndrome, and hemifacial spasm. So that's my main disclosure. I typically inject between 5 and 7 patients a week. And my team, since the LCD has come into play, our team at the University of Iowa has had a significant burden from these changes. And I recognize the need for implementation of new guidelines. But I also just wanted to point out that our team, we've calculated, has spent about 50 hours a week working on getting approvals for these patients. Also, the private practice colleagues throughout the state of Iowa, I practice at the University of Iowa, have chosen not to proceed with these injections because of this administrative burden. So we're getting new patients at the University of Iowa. We've had 9 denials in the last month, and we've been able to get 2 approved through appeals, and we're in the process of a 3rd round of appeals from the other 7. So that's my background and where I come to for this information. So thank you. Next slide, please. The first recommendation we have is revising General Rule number 16 in the general notes, which states Medicare will allow payment for 1 injection per site, regardless of the number of injections made into the site. And a site is defined as 1 area. We would recommend that because a code is reported once for a series of injections, that this be reworded to state an applicable CPT code is reported once per eye or site of face without regard to how many injections are performed. And we think that this would clarify the policy. Thank you. Next slide. When looking at thinking about blepharospasm, the initial dosing of 1.25 to 2.5 units per the 3 injection sites of onabotulinum toxin A, which I'll refer to as Botox, is clinically insufficient in dose and number of injections. The typical treatment requires 5 to 9 injections per eye, totaling around 25 units to effectively manage the blepharospasm symptoms. And this total dose of 25 units is consistent with the initial dosing guidelines for incobotulinum toxin, or ZMM, which has a similar efficacy and safety profile as Botox. So we recommend that the initial dosing regimen for Botox be revised so that both Botox and ZMM be allowed for as many injection sites as necessary, up to 25 units per eye. Thank you. Next slide. When talking about Mage syndrome or blepharospasm with orofacial dystonia, we know that about 50% of patients with blepharospasm progress to Mage syndrome, and that's when you have both the blepharospasm around the eye, and then you also have the oral and lower face symptoms and dystonia as well. And this requires that we increase the dose of the injections around the facial muscles to get symptom relief. The LCD should therefore be revised so that Botox is allowed up to 50 units per eye, aligning with the ZMM dosing guidelines. So we would ask for that. Also, there's no clinical rationale to exclude ZMM for coverage of the blepharospasm with orofacial dystonia. And then Botox and ZMM are both used interchangeably in the practice for this condition. ZMM actually may be a lower cost option as well. So we would recommend that those be considered equivalent. Thank you. Next slide. And when looking at hemifacial spasm, there's really no clinical justification for waiting 1 year for these patients before you can increase the dose or change the number of injection sites for patient relief. This would prevent them from having up to 3 more treatment sessions, and these patients really are suffering. So the increased dosing based on clinical response should be allowed to be performed at the discretion of the physician at the next treatment session based on the inadequate response to prior treatment dose. And actually that should apply throughout, both with blepharospasm, Mage syndrome, and hemifacial spasm. But we'd like to have that clarified for hemifacial spasm and the duration of time reduced. In terms of strabismus, the initial dosing for Botox, 1.25 units to 2.5 units in any one muscle, is appropriate only for common or typical strabismus. But sometimes there's paralytic or large angle strabismus that requires doses up to 10 units. And so we'd like to have that increased. Also, the drug vial size, when you're talking about 1.5 units versus 10 units, still the drug vial size would be the same. So there really would be no cost difference. Thank you. Next slide. When looking at all of these medical eye conditions, there's no provisions for patients who have been receiving doses higher than what would now be authorized in the proposed LCD. And this is what we're facing with our patients at the University of Iowa right now. So there's this risk of care disruption despite positive outcomes and safety. Many of these patients have been getting these treatments. I've been injecting them for over 10 years, and suddenly they're being told that they're not able to get the treatments that have been working well for them, that have allowed them to return to driving, return to work, that kind of thing. And so we're seeing these denials, and there's a potential for more, of course, and restriction of medically necessary treatment. So these patients have had proven treatments that haven't changed. Nobody enjoys having these needle injections on the eyelids. It can be uncomfortable. And so we're really doing it to help them return to their quality of life and their functioning. The mandatory clinical scales are unnecessary and burdensome. The requirements increase the administrative burden, as I spoke about, has been happening with our department, and there it isn't improving patient care. We're also being asked to place scales and for visits that were before the time period of the LCD, so we're having to go back and try to add those back into notes as addendums. And reporting quality of life from prior injections as a narrative element in the note, really establishing medical necessity that way, we think for ongoing treatment should be sufficient. Thank you. Next slide. So in summary, the American Academy of Ophthalmology, the American Society of Ophthalmic Plastic and Reconstructive Surgery, and the North American Neuro-Ophthalmology Society all encourage policy revisions to support physician discretion and patients' access to this necessary medical care. We'd ask to reconsider the restrictive dosing limits and escalation timelines, align the policies with real-world ophthalmic practice, reduce administrative burdens while preserving safe and effective care. Hopefully this will allow patients to get treatments closer to home as well if they're not needing to come to the main universities, if other practices can do it throughout our states. And our organizations will follow up with detailed recommendations in our submission of written comments supporting literature as well. So thank you very much for this opportunity, and I would be happy to answer any questions.
Thank you so very much. Do any of my fellow CMDs have any questions for our speaker?
This is Dr. Shenin, no comments, thank you.
No comments. Thank you very much for the presentation.
Thanks for the presentation. No comments.
All right, great. So,
Thank you, appreciate it.
Yeah, thank you so much, Dr. Shriver. Appreciate the thoughtful attention. And our last formal presentation is actually being given by one of our very own CAC members, Dr. Andrew Pugh. He helped us out on many occasions and has really put in some extra effort here to try to pull together comments from his from where he actually represents as a CAC member, which I think might be a rare event, but certainly the first I've seen. So without further ado, thank you so much, Dr. Andrew.
Thank you, Dr. Vlahakis, and you're too kind. I'm just a busybody, I guess. But thanks to you for leading the meeting. And hello, everybody. My name's Dr. Andrew Pugh. I'm an ophthalmologist and a glaucoma specialist at the University of Iowa, and I am the CAC representative for ophthalmology in Iowa. And I'm here to represent our collective concerns regarding the LCD, both in its current form and its proposed draft iteration. I will disclose one unrelated conflict of interest. I've received equipment support for glaucoma research from MNS Technologies, which is definitely not pertinent to this discussion. So I'll briefly share some observations from our collected clinical practice and suggest a few targeted clarifications. Mr. Staley, happy to advance to the next slide. Thank you. So in practice, we're seeing consistent friction in obtaining coverage for especially established patients. And this includes repeated non-affirmations despite stable long-term therapy, delays in care due to prior authorization cycles and appeals, and significant administrative burden requiring resubmission of multiple clinical notes. Most importantly, these are patients with mostly chronic blepharospasm whose functional vision, reading, driving, daily activities all depends on maintenance of consistent treatment, and interruptions can and are leading to meaningful decline. Happy to move on to the next slide. Thank you. These are not isolated issues. They seem to be occurring across different physicians, providers, and patients, even when care adheres to FDA labeling and clinical benefit is documented. In some cases, outcomes have appeared to conflict with WPS educational guidance provided in recent webinars. And so taken together, this suggests that what we're seeing is not simply a variation among reviewers, but it's perhaps ambiguity in policy language that may be leading to a rigid or inconsistent interpretation. Happy to lay to the next slide, please. Thank you. So I'll briefly highlight 4 areas where clarification may improve consistency, the first being timing of post-injection scoring, objective scoring documentation requirements and expectations, interpretation of dosing, particularly the 5 units language, which I acknowledge, Dr. Vlahakis, you mentioned it was removed in one section. I'll still mention one area that it persists in the draft LCD, however, and also injection interval interpretation. These issues are interrelated and they drive many of the downstream non-affirmations we've been seeing. Next slide, please. So starting with the timing of post-injection scoring, the proposed requirement for objective scoring after each injection may benefit from clarification because as written, it may be interpreted to require a separate post-treatment assessment for each injection. In practice, this would effectively create an additional visit per cycle, adding burden for patients in terms of travel and copays, increasing clinic capacity demands, and increasing Medicare utilization. From a clinical standpoint, immediate post-injection scoring is also not meaningful as therapeutic effect has not occurred, and a lot of the effects afterwards are related to the injection of fluid volume, and the actual neurologic effect hasn't taken effect yet. A more workable standard would be baseline objective assessment along with documentation of functional response, duration of benefit, adverse effects, and recurrence all at the next treatment visit. Next slide, please. And regarding the objective scoring documentation, we are still seeing non-affirmations consistently even when validated scales such as the Jankovic rating scale are being used, which suggests the issue is not whether the objective scoring is performed, but how it is documented. The LCD does require objective assessment using a scale, but it does not define how that score must appear in the note, how follow-up assessments should be structured, or whether longitudinal documentation is acceptable. And in practice, what we've seen is this seems to be resulting in expectations that the score be presented as a discrete record within each individual note with limited ability to reference or supply prior documents referencing scores from prior visits. For chronic conditions like blepharospasm, where treatment response and duration of benefit are tracked over time, allowing longitudinal documentation across signed clinical records, including allowing summary and synthesis of those collected records, would better align with real-world care. Next slide, please. And for dosing, we do appreciate that in the proposed LCD, the prior language under the section for botulinum toxin A, under subsequent botulinum toxin injections referencing the up to 5 site units per site language, we appreciate that that has been removed. That change is helpful. However, in the very next section, under subsequent dosing guidelines, the draft LCD still includes the statement that, quote, injecting more than 5 units per eye provides little additional benefit. This is a point of concern for the specialty communities, mostly because FDA labeling describes dosing per injection site, not per eye, and standard treatment patterns do involve multiple injection sites per eye. In addition, both clinical experience and available literature support individualized dosing, often in excess of 5 units with sustained efficacy and acceptable safety. So we're concerned that this language may be being interpreted as a per eye ceiling, which is not consistent with FDA labeling or real world practice, and may lead to underdosing and reduced treatment durability. Clarifying that dosing should be interpreted on a per site basis, not per eye, and that individualized dosing based on clinical response is appropriate would, we think, improve consistency. Next slide, please. And finally, regarding injection intervals, we are seeing non-affirmations when intervals extend beyond the 12 to 16 weeks approximately, often with requests in the non-affirmation to explain gaps in treatment. The LCD defines a minimum interval between injections, but it doesn't specify a maximum interval or how longer intervals should be interpreted. In practice, this may result in an unintended expectation of fixed treatment frequency. And for chronic conditions like blepharospasm, duration of effect is variable, and stable patients may extend intervals or delay visits due to real-world factors without loss of medical necessity. You can imagine folks just not being able to make it to their appointment. Certainly Iowan blizzards and things will really affect whether somebody can adhere to a visit schedule. There is also a structural issue here. Prior authorization is required before each visit, but the reason for a gap in care often cannot be determined until the patient is evaluated. So it's a chicken or egg problem. Clarifying that longer intervals do not invalidate medical necessity would improve consistency. Next slide, please. So in closing, we certainly support the goals of the LCD and appreciate the effort to standardize care. Our community would suggest a few targeted clarifications, clarify the objective scoring timing to avoid unnecessary visits, really, defining acceptable documentation for objective scoring, and permitting the usage and the submission of longitudinal clinic records or synthesis and summary of them. We'd also recommend clarifying dosing language to distinguish per site from per eye interpretation and ensuring consistency across sections of the LCD. And we suggest clarification that longer injection intervals do not invalidate medical necessity. These are all clarifications of implementation, not necessarily requests for expansion of coverage. They would align the policy with clinical pharmacology, real-world practice, and WPS guidance. I very much appreciate everybody's attention and time for letting me speak. Thank you very much.
Thank you so much, Dr. Powell, for that thought and for collectivizing your section comments for us. I wonder if any of our illustrious CMDs have any questions for Dr. Powell?
This is Dr. Shenin. I have no questions, but just wanted to thank the Dr. Powell for his commitment to the program, our beneficiaries. Thank you.
And I second my colleague's thoughts. Dr. Powell, this is Dr. Campos. Thank you so much. I have no questions. I completely agree with you.
And I'll be a third ditto here. Okay, again, Dr. Powell, thank you so very much for your attentiveness, okay, for your dedication to our beneficiaries, that this policy will align with others appropriately so that our beneficiaries get the best care. So very much appreciated all your work.
Thank you.
Okay. Well, I would hesitate to follow any of those speakers. However, we would like at this point to solicit any comments on the proposed LCD DL 39909 from the general public. When you want to make a comment, raise your hand. I see some folks have already figured that out, or press *5 on your touch tone phone, and we'll take your comments in order. Mr. Staley, do you mind moderating this particular part? Because I just can't see which order the hands are being raised in.
I understand. It's Citrix. Yes, we've got Dr. Brad Orris. He's a CAC member. You're first up. Go ahead.
Yeah, can you hear me? This is Brad Orris. I'm a urologist in Indiana with Urology of Indiana. Speaking on behalf of my practice, and I have no disclosures. And as a urologist who does many Botox patients, the last 2 months since this LCD have come into effect have been quite traumatic for many of our patients who have been stable on care for, over a decade, as Botox was initially approved in 2011 and 2013 for the indications we're speaking about. The first thing I wanted to discuss was related to anesthesia. Line 13 gives a blanket prohibition on conscious sedation or monitor anesthesia care for all uses of botulinum toxin injections, and specifically in regards to the urologic diagnoses of that we use it for putting a scope into a patient's bladder and injecting 20 or 30 injections into the wall of the bladder is pretty different, I think, than injecting peripherally and in the head and neck, as mostly these are not that those are not uncomfortable, but putting a scope into the bladder can be different. But there are two specific conditions in regards to neurogenic bladder. Many of these patients with cervical spinal cord injuries have a condition called autonomic dysreflexia. It's mentioned in the references within the LCD. And they can literally get a life-threatening elevation of blood pressure during any stimulation, essentially below their waist. So bowel and bladder stimulation can cause autonomic dysreflexia, which can cause, extremely high elevations in blood pressure. I literally have a patient who I used to do awake, but then she just couldn't tolerate it because of the blood pressure elevations, and she's been getting anesthesia for her Botox injections. She has a high, or not a high, but a kind of a low cervical spinal cord injury. And she's going to have to choose, given these guidelines, whether she wants to, have a risk, life-threatening autonomic dysreflexia, or find some other way to manage her bladder. And then the second would be in regards to patients with interstitial cystitis. The LCD provides coverage for patients who have interstitial cystitis, but by definition, these patients have extremely painful bladder conditions. That's what interstitial cystitis is. And we're going to tell these patients who have very painful bladders who want to try and control their symptoms with Botox that they have to have a scope put into their bladder and injected awake. For many of them, it's not going to. It's going to be just not even an option for them. So I'm not necessarily asking for a blanket coverage for any anesthesia, but much like any other Medicare framework for other procedures, if there's medical necessity in these rare circumstances where a patient can't tolerate it, I think anesthesia beyond local should be allowed. Second comment would be in regards to the dose escalation. The gentleman from Avi already made the point about with overactive bladder in certain circumstances going from 100 to 200 units. It's well supported by the literature, again, that's already referenced within the LCD. I would add on to that, going from 200 to 300 units in our patients with neurogenic bladder is oftentimes necessary for them. These are patients who typically are already catheterized in their bladders. The concern with dose escalation is that it increases the risk of urinary retention. But the way I explain it to my patients is, we're going to use the Botox to hold the urine in. You're going to use a catheter to get the urine out. It's completely revolutionized care for these neurogenic patients with spinal cord injury, multiple sclerosis, Parkinson's disease, strokes, any of the neurologic conditions causing bladder dysfunction. And if they're already catheterizing, going from 200 to 300 units is well established in the literature. And then the final point, again, was already somewhat made by the other colleague from Iowa regarding the symptom scores for our patients who are stable on care. The LCD seems to require baseline symptom scores, which is completely reasonable. And then after each Botox toxin procedure and at each follow-up assessment. And again, many of our patients are stable. They've been doing this for years. They come every 4 months, every 6 months, they get their Botox. And now we're seemingly having to bring them in for an additional visit, which Medicare is going to have to pay for. And the patient's going to have to get to the office for an assessment that in my opinion, is not necessary for them. So just some clarification regarding the timing of the interim follow-ups if we truly need to bring our patients in for visits that they're not currently getting just to do a symptom score would be helpful. And that would be, so again, regarding the anesthesia for certain patients, the dose escalation and the symptom score timing. Thank you.
Excellent, thank you. That's a perfect time for me to remind all of our speakers, formal and informal, to follow up your comments with something written to Medicare policy comments at WPSIC.com, and also any of the materials or articles or evidence that you reference, please send that in PDF or Word document form. Again, I can't stress this enough. We can't follow links or other citation websites. Okay, Rich, up to you. Any other hands raised?
Yes, we have a Kimberly Kuman.
Yes, thank you. My name is Kimberly Kuman, and I serve as the Executive Director of Dysphonia International. I have no conflicts to report. I've had the privilege of working closely with individuals living with spasmodic dysphonia, which is also known as laryngeal dystonia, and have learned firsthand how this condition affects their ability to communicate. It is a neurological disorder that makes speaking difficult and at times nearly impossible. Botulinum toxin injections are the standard of care for many people and essential for them to maintain their voice. For many, there are no other effective treatment options. This treatment is not consistent, and it can sometimes be unpredictable. And that's why it must be important for it to be tailored for the individual. And this kind of timing matters. When it's delayed or restricted, the impact is immediate. People struggle to speak, work, and enjoy everyday life. We're concerned that the proposed policy might introduce limitations that do not reflect this reality. Restrictions on injection timing, technique, or access to tools like EMG guidance or sedation offer barriers to care that allow people to function. We appreciate the changes that were made from the original draft of July of 2024 and the clarification on the different forms, but we would respectfully urge that the policy support the physician discretion and ensure timely access to treatment. For this community, that is the difference between having a voice and being heard. Thank you.
Thank you. Is there anyone else who would like to make a comment? Please press the raise hand icon or *5 if using dial-in. Charlene Hudgens. Hi, Charlene. Can you unmute your phone? Press *6 if you're dialing in, or just click on the unmute icon.
Hi, this is Charlene. It took me a while to find the unmute button. Can you hear me now?
Yes, we can. Thank you.
Okay.
You may proceed.
I would just like to mirror a lot of what Kimberly said. My name is, as you know, Charlene Hudgens. I am the Executive Director of the Blepharospasm Research Foundation, and I work with thousands of blepharospasm patients over the decade or more that I've been here. And something that Kim said was that each treatment needs to be tailored to the person. So what we've been seeing laid out are standardized treatments, but I know from experience in blepharospasm, it's never one size fits all. Everyone's spasms are different. They manifest in different ways. But the thing that I find most concerning about what we're talking here is the 12-week minimum. I know hundreds and hundreds of patients for whom their botulinum toxin injections do not last 12 weeks, that they sometimes last 10 weeks. So that means that you're going to have people who are blind for a couple of weeks. That creates dangerous situations for them. And so I just want to emphasize the tailoring of the treatment. We have gathered together lots of information that I can share with you guys to show the safety of having those injections more often than every 12 weeks. And it's not something they're asking for frivolously. This is something that is medically necessary. So that's just what I wanted to share.
Thank you. All right. R. O'Hearn.
Thank you. Can you hear me?
Yes.
Yes, we can.
Great. Thank you. I'm Rebecca O'Hearn. I'm the Patient Accounts Manager for Department of Neurology at Washington University School of Medicine in St. Louis. I'd like to also echo what Charlene just said and also dovetail on prior comments that it is very limiting for our providers in that dosage and interval both need to be tailored to the individual, and we're not seeing a mechanism in this LCD to accommodate for those outlier cases. We would like to know that we have some assurance that for those individuals who, as many speakers have mentioned, have had multiple years of more frequent interval or higher dosage, we'd like to know that we have some accommodation and some leeway. We appreciate, again, as others have said, that there is a need to standardize treatment, but there is also a need to accommodate those outlier patients as well. So we wanted to dovetail on that. And once again, we would also like to request, as we have multiple times in the policy comments mechanism, we would also like to once again advocate for diagnosis code G24.8 to be added to the spasticity group for coverage, because there are occasions when dystonia is truly not coverable by another diagnosis code. It is other dystonia. We would like to see that added to group 18 on the associated billing and coding document for coverage. Thank you very much.
Thank you. Next up, we have Dr. Jeff Craver. He's a CAC member with WPS.
Hello, this is Dr. Jeff Craver, and if I may, I'd like to introduce my wife, Ann Craver, a PhD, and she's suffering from blepharospasm. She suffered from it for 31 years, initially diagnosed at the Mayo Clinic. So I'd like to have her say a few words about her experience.
Yes, thank you for allowing me to speak. I think that this 12-week rule is highly burdensome and not reasonable. I'd just like to reiterate what Charlene Hudgens had to say, our executive director for the Blepharospasm Foundation, that it just, you can't, it has to be tailored to the individual sufferer of blepharospasm. And I have been receiving these shots, like my husband said, for almost 31 years now. And I am on either the 9 or 10 week interval. And this 12-week rule is really arbitrary, and it will definitely not fit my needs. And I need the Botox. It's a medical necessity for me. Otherwise, I'm legally blind. So thank you.
Thank you very much for your comments and your direct testimony. Do we have any other comments? Raise your hand or press the *5 on your touch tone phone. Okay, Dr. Riza Farid, another CAC member. You may speak.
Thank you. I was caught by the original topic, which was cervical dystonia. I'm from the University of Missouri, CAC member, yes, Department of Physical Medicine and Rehabilitation. The initial discussion of cervical dystonia mentioned using a Twister score and approving for moderate or severe cervical dystonia or torticollis. But the Twister score has no correlation with moderate or severity of the disease. So there wouldn't be a Twister score of, say, 15 out of 24. There's no standardization for that. It's been inter-rater reliable, but I don't know how you'd measure, like, is the intent to look at the Twister score and somehow interpret that patient as not being severe enough, perhaps, for receiving the treatment? So, of course, I'd recommend abandoning, as the original speaker, I think, from Ipsen had said, the discussion related to that.
Thank you. Any other comments on this LCD? Okay. Hearing none. Well, Dr. Fareed, your hand is still raised. Do you have another comment you wanted to make? Okay. All right. Hearing none, I will turn things back over to Dr. Vlahakis, and floor is yours.
I think I see a hand. 11th hour. Do you see it, Dr.?
There is something in the written comments. It's a
Oh,
question,
very good.
although typically we do not take questions, but it says in the LCD policy, cervical dystonia, the section indicates of coverage, initial botulinum toxins injections, number 7 state the initial Botox A dose is based on the patient's head and neck position, localization of pain, muscle hypertrophy, patient response, and adverse event history. Use lower initial dose in botulinum toxin naive patients. However, the initial dosing guidelines omit Anabox A highlighted. Seems initial dosing guidelines are missing Anabox A. Please clarify.
Yeah, if those comments can be sent to response to comments, that would be very helpful because then we can take them under consideration. Thank you. That was a very good point, Rich. I'm glad we had a chance to clarify that. So I want to thank everyone for attending the open meeting. Please remember that only comments or questions submitted to Medicare policy comments at WPSIC will receive a written response. When you write to us, include the topic of the LCD on the email subject line. If you have supporting scientific literature, attach that in either a PDF or Word document form to the policy comments mailbox. Again, WPS cannot follow any links that are emailed. I want to thank my colleagues here at WPS for participating. The reason it goes smoothly is because we have someone like Rich working so hard behind the scenes to keep us on task and make sure that we have all of our materials in front of us. This concludes our meeting. Thank you very much and have a good afternoon. We are adjourned at 3:08 p.m. Eastern Standard Time and 2:08 p.m. Central Time.